The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. I'm Tony Urbanek, and we are here for the next episode of TMD Demystified. Welcome. Today, I've picked a topic that can be used and understood specifically to understand why it is so important to understand the effect of inflammation on all the symptoms associated with TMD. When this portion is understood, then it makes complete sense, total sense, as to why one would want to focus on the treatment of TMD on only finding ways to decrease inflammation. Let's put it a different way. If you decrease inflammation and it resolves all of the symptoms associated with TMD, why would you specifically, or one generically, not want to just focus on decreasing inflammation instead of doing multiple other treatments that may address a symptom or two, but don't actually address the common denominator cause? And I wanted to put this all in one place so that, again, it's been addressed in multiple other episodes for sure, but I wanted to put it all together so anyone who is really interested in the nuts and bolts, the actual focus of the whole technology of treating TMD, it's all there within the next 25 minutes. So the title today is Inflammation, Connecting the Dots to Explain the Symptoms. Connecting the dots to explain the symptoms, starting out with inflammation. So we know that the common denominator of temporomandibular joint disorder is inflammation within the joint. In fact, that is how you define it. If you push on a joint and it hurts, the joint is inflamed. And if the joint is inflamed, is the definition of TMD. The definition of TMD is not the position of the disc, or the definition is not necessarily the cascade of symptoms or what symptoms are present or unpresent. Those are just symptoms, and there is a well-known list of symptoms of TMD, but it is not the definition. The definition of temporomandibular joint disorder is inflammation within the temporomandibular joint, caused by blah, 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 blah. All right, so this is what I stumbled into. This is what I learned, and for the past several years, I have delved into it very deeply, but it didn't have to go very deep because all the information has been there for at least 50 to 60 years in the literature, well understood in the literature. This is not cosmic material. This is all in place. So we started out with patients saying, if I put my tongue between my teeth, it feels better. We separated the back teeth, knowing that it unloads the joint. When the joint is unloaded, the inflammation goes down. But here's the topic for today specifically. So when you make the inflammation go down, when you can decrease the inflammation to the point where you do this little maneuver and it doesn't hurt, i.e. the inflammation is diminished, how does inflammation in the joint cause all those disparate symptoms? What is the mechanism or mechanisms to cause all those symptoms? Again, each individual has been covered in different places in the episodes, but I wanted to pull it all together all together at the same time. So hopefully it's logical, it makes sense, and some of you will go, aha, you'll have the aha moment and decide, oh, we don't need to treat this with drugs. We don't need to treat it with machines. We don't need to treat it with occlusal equilibration. We don't need to treat it with this or that. We just need to get rid of the inflammation. And the best way to do that, obviously, is unloading the joint. And I believe the best way to do that is unloading the joint with your Bannock device and protocol. All right, inflammation in the joint. What the heck is it that inflammation in the joint can cause all the symptoms? Well, what are the symptoms? Again, well-known, well-accepted in the literature symptoms associated with TMD are frequent or recurring headaches, earaches, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, fullness in the ears, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of locking. Those are the well-accepted symptoms that I reel them off multiple times a day when I'm seeing patients. So this mechanism is the one thing that I already knew years ago when I first began investigating TMD, but I didn't know it overtly or at the top of my mind. I actually was there all the time. But the orthopedic surgeons know this phenomenon for a long time, and they call it joint splinting. And I've explained this before, but we'll start here. If you have an inflamed joint, an autonomic signal goes from the inflammation within the joint to the central nervous system in the brainstem. Does not have to go high. You're not aware of it. It's just in the brainstem. And it gives the signal that the joint is inflamed. When the brainstem receives that signal, it processes a signal and it sends a signal back out, don't move the joint. Our orthopedic colleagues have been aware of that for 50 or 60 years, and they call it the phenomenon in the vernacular. There's a more specific name, but more in the vernacular, the joint splinting phenomenon. In other words, the signal goes out from the brainstem to splint the joint, and it's well known, described by the orthopedic colleagues in the elbow. If you have tennis elbow, sends a signal to the brainstem, the elbow's inflamed, the brainstem says don't move the elbow, and you have the phenomenon of tennis elbow, where the pain is not necessarily in the joint itself, but it's where the muscles are attached to the bone, because the muscles get the signal to tighten up on both sides of the elbow, and the insertion and origin of those muscles pull on the periosteum, which pulls on the nociceptors, which creates the pain. Muscles don't hurt. It's where it pulls on the bone, and that's where you get patients complaining of tennis elbow, but it's not just in the elbow. It's the whole part here that is tight and tender and painful. Well, when I realized, and it wasn't right off the bat, when I first discovered how well unloading the joint decrease the symptoms, I had to then figure out how does unloading the joint decrease each and every one of those symptoms. So that same phenomenon that applies to the elbow that our orthopedic colleagues have known forever applies to this joint. This joint is just like any other joint. It operates the same way. It is not a special joint. It has some special characteristics, but don't let the dental schools convince you that this is so unusual that you'll never figure it out. That's not true. It's just a joint, and it operates like any other joint. It has muscles, it moves, it has lever arms and fulcrums. It has a meniscus. So when this joint gets inflamed due to bruxism, functional malocclusion, and acute trauma, the signal goes to the brainstem and says, tighten up. Well, what does it send? Where does he send that signal to? Well, it sends the signal to the muscles that move the mandible, that move this joint. And it doesn't necessarily send the same signal to equally to each and every one of those muscles. And we know we have multiple facial muscles, 5 major muscles that move the mandible in different directions, different times, different manner. And so, but when the muscles get the signal to tighten up, they will tighten up. And when they tighten up, they will pull on the bone in different areas. And where it pulls on the bone and pulls on the periosteum and stimulates the nociceptors, then the signal goes back to the brain stem and the sensors of pain, and it hurts. And so, first of all, so the muscles of mastication get tight, and the patients will complain of different pains in different areas of where the muscle, either origin or insertion of that muscle is. And patients will come in, and if you see any number of these patients, you will observe this for yourself. I do not ask you to believe me. I ask you to observe it for yourself. They will come in and they'll say, it hurts right there, doc, every morning, right there. Or it hurts right there every other morning, and then every opposite morning, it hurts over here, right here. Well, when they bring that to their PCP, even to their dentist, that's when the PCP says, I think you're crazy. That doesn't make any sense. Well, it makes perfect sense when you understand the phenomenon of joint splinting, the autonomic nervous system giving signals to the muscles of mastication to tighten up, not all symmetrically. And patients will complain of right here where the mylohyoid inserts, or they're right here where the masseter inserts. Or patients frequently talk about having sinus pain, or where the muscles up here will get tight and it hurts. To them, it just hurts. It must be my sinuses because it hurts right there. I have sinus headaches. No, you have muscle tightness. You can call it a headache if you, it is a headache. This is your head, and if it hurts, it's a headache. But when you make the inflammation here go away, that signal diminishes, and it no longer stimulates the muscles to get tight, and whatever the symptoms are around the head and neck, muscles of mastication, they diminish. And those kinds of pains, those kinds of headaches, whether it be up here or down here, will go away. Now, that is the exact same phenomenon that causes the neck pain, because when that series of autonomic signals does not stop, and for whatever reason you don't get treatment, or you continue to brux and grind, or whatever, the inflammation doesn't go away, sooner or later the brainstem says, in its own language, which we don't fully understand, in its own language, it says, look, I told you to tighten up the jaw muscles, and you're still complaining the muscles that there's inflammation in the joint. So now what I want you to do, besides tightening up all the jaw muscles, I want you to tighten up the neck. And the second most common symptom of TMD is neck pain. The most common symptom of TMD is headaches, different kinds of headaches. The second most common symptom is neck pain, not ear pain. And patients will complain of, my neck hurts. And it's tight right up in here, and it's painful. Every morning it's really painful right there. Not everybody says the same thing. In fact, all these symptoms bounce around, and all of them vary from patient to patient, because each nervous system between patient to patient is phenomenally different depending on their age, their history of other mechanical or physiologic problems, the amount of drugs that they've been on or taking for any length of time. All of those vary what causes different patient responses. But the point is that the signal goes from the inflamed joint to the central nervous system. The central nervous system now tighten up the neck. And patients will complain of upper shoulder pain, upper back pain, right there, base of the back, the insertion of the sternocleidomastoid. They'll come in, they will point to the insertion. It's happened, I've seen it 100 times. They'll point right there to the mastoid process and say, every morning it hurts right there. And oh my God, when I push on it, even hurts more. All right, and then when it continues on, and this is the one that I don't know whether I discovered this or not. I know of one other clinician up in Cleveland at the Cleveland Clinic who has written upon this symptom, and verifies it, and that is arm, hand, finger tingling, and numbness. But that is easily, anatomically, because of my training in anatomy and cell biology, it's there in front of us all to look at. When the strap muscles on the side of the neck get the signal to tighten up through the strap muscles, or the scalene muscles, if you remember the proper name. Scalene muscles on the side of the neck get the signal to tighten up. They will tighten up, and through the scalene muscles runs the brachial plexus. And when the brachial plexus gets squeezed, it will cause arm, hand, finger tingling and numbness and some pain. And of course, patients will go to their orthopedic surgeons and they will talk about their finger numbness. And we've had patients who've had actually surgery on their wrist, when actually the symptoms were originating from the temporomandibular joint and squeezing the muscles, squeezing down on the brachial plexus. And when those muscles relax after the inflammation in the joint goes away, those symptoms go away. Not magically. It's not magically, it is expected. It will go away. And you can expect it. So we've covered the majority of painful symptoms, and it all has to do with that well-known orthopedic phenomenon that they call joint splinting, and that the joint splints. This joint will splint first the muscles of mastication, then the muscles of the neck, and when it goes deeper, they will even complain of pain in the chest. And I have had 3 separate patients, 2 of which ended up in the emergency department thinking that they was having a heart attack, because this muscle was so tight. Now, they didn't describe it as I have a tight muscle. They described it as I had tremendous pain in my chest. Of course, they went to the emergency department. They got an ECG, and that checked out to be totally normal. Draw some blood. No, sir, you're not having a heart attack. Well, why does it hurt so much? Well, that same phenomenon will, say, tighten up, and the same nerves go into the pectoralis muscle here. And if that pectoralis muscle gets tight enough, it will pull on its origin insertion, creating a huge amount of pain. Now, that is not that common. I've only seen 3 cases, but 2 of them ended up in the emergency department. The other guy just toughed it out, I guess. But he talked about how much this hurt, along with his shoulders and his neck, etc. All right, so that totally explains a portion of the symptoms, which I reeled off. The ones I didn't cover so far, and I have covered in my other episodes, but we're going to include them here, are the 3 in the middle that include tinnitus, ringing in the ears, subjective hearing loss, fullness in the ears, and vertigo, various kinds of dizziness. And there is a distinction between dizziness and vertigo. The ENTs distinguish it in the literature, vertigo being continuous versus dizziness, which is intermittent. But the point is that it's dizziness. Now, how does inflammation in this joint, in these joints, cause one or all 3 of those symptoms? And by the way, as I've discussed earlier, tinnitus, subjective hearing loss, and vertigo are the 3 components of Meniere's disease. It's actually how Meniere's disease is defined. Meniere's is defined as tinnitus, subjective hearing loss, and vertigo. And the ENTs have no solution for Meniere's disease, but we know that patients who have inflammation in these joints, when the inflammation goes away, the tinnitus, the subjective hearing loss, and the vertigo diminish and go away. So how does that happen? How does inflammation in these joints cause those to occur? Well, I've covered it again before, but bringing it all together. Inflammation in this joint is only literally 2 to 3 millimeters distant from the middle ear. And the middle ear contains a solid piece of bone within the temporal bone and contains all of the mechanisms for hearing and to keep you upright, your vestibular mechanism. And when inflammation gets into the middle ear, it will stimulate inflammatory response and stimulate the effect of tinnitus, subjective hearing loss, and vertigo. It's just the inflammatory fluids, possibly cells, but for sure fluids, and that we've identified anatomically an anatomical structure in Gray's Anatomy, which literally is an opening from the glenoid fossa of the temporomandibular joint into the middle ear, called a petrotympanic fissure. It is a fissure that allows inflammatory fluids and exudates to enter the middle ear, where the vestibular mechanism and the hearing mechanism reside. And those, I tell everyone because of experience, I tell them this because that is what I found, that is what we see, is that inflammation inflammation in the middle ear takes a while to get there. That's why inflammation in the middle ear and tinnitus, vertigo, and subjective hearing loss are not the most common symptoms. They don't show up first. But if you have inflammation in the temporomandibular joint long enough, on many, many cases, like a huge number of people, the inflammation will infiltrate into the middle ear and those symptoms will arrive. And you don't have to have all three of them at the same time. You may have one, you may have two, you may have three. What we have found, that tinnitus is almost the last symptom to go away. We have treated multiple people, and it's in our study also, and which states the resolution is real, that over a period of time, slowly, those symptoms diminish, with tinnitus being almost always the last symptom to go away. I do not know why tinnitus hangs on longer than the other two. Subjective hearing loss, meaning the fullness in the ears, is almost always the first one to resolve, and the vertigo is a close second, and tinnitus is a distant third, Although we've had multiple patients who their only symptom on arriving because of what we do here and word getting around that we do treat tinnitus, they come in, that's their only symptom. And we have already had multiple patients that over a period of time, the tinnitus will diminish, even though that's their only symptom. So in TMD, you don't have to have all these other symptoms. And there's a lot I can say about this. You know, men present most often, instead of complaining of pain, they will complain of tightness, and they will most often complain of one or more of those three middle symptoms: tinnitus, subjective hearing loss, and vertigo. But because of the petrotympanic fissure allowing inflammatory exudates and fluids to get into the middle ear, is how those three symptoms come directly from inflammation within the joint. And then finally, various kinds of locking. And that is, again, anatomically, physiologically, histologically, very easy to understand when you understand a little bit of anatomy, physiology. And that is, the meniscus itself is held together by ligaments, posterior attachments, anterior attachments. And as inflammation within the capsule of the temporomandibular joint progresses over time, those ligaments get loose, which allows the meniscus to get loose, which is why one of the earliest signs, not symptoms, but signs of TMD is clicking, click, 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 click. And I can't tell you literally hundreds, thousands of young females who come in at age 40 and they say, oh, when I was 16, I just had this click and click and click. And did it hurt? No, it didn't hurt. It was great. It's this wondrous click, 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 click. Well, that's not a good sign. And it's a sign that the meniscus, that you have inflammation in the joint, and now the meniscus is loose. And then sooner or later, the meniscus within the temporomandibular joints gets loose enough to come forward, ball up into a little ball. And now when you move forward, you bump into your own meniscus, which is an impediment. And the first stages of it finally clicks back with a louder noise and some pain, usually. Louder noise and pain. describe more as a pop than a click. And then after a while, whether it be a month or 5 years, eventually it gets so dislocated, it sits up here in front, balls up into a little ball. And when you go to open, you bump into your own cushion, you can't get past it. And now you can only open halfway to 25 or 30 millimeters rather than 45 or 50. See it all the time. And that is how inflammation in the joint will cause locking of various kinds, closed locking, closed lock of the temporomandibular joint. And when the inflammation diminishes, the synovial fluid will come back and regenerate to a more, to a less viscous and a fluid that is more able to allow the meniscus to move back and forth, and the locking will diminish. And we see it in almost all cases. Can't say that by unloading the joint and decreasing inflammation, you're gonna solve all cases of locking. But I would, and again, we can study it, we can get you numbers, et cetera, but I would say at least 90% of the locking, closed locking, improves or completely goes away once the lubrication of the synovial fluid comes back to normal. If it lubricates back to normal, it's not as sticky, and the meniscus, which is now kind of sticky and stuck up here, will come back into a more normal, not perfect, not anatomical position, but it'll come back. And although it still may make some noise, click, 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 it will stop locking out here, and you can get past it because the meniscus will come back in a more normal position. Again, totally dependent on the degree and amount of inflammation within the joint. So trying to do surgery on the joint and doing external manipulations of the meniscus, whether you take it out or reposition it, try to fix it in some way, is not addressing the problem, because the problem is actually inflammation. And as a surgeon who has done over 2,000 temporomandibular joint surgeries, half of them through a scope and half of them open joint surgery, I can tell you that manipulation of the meniscus is not the answer. And it's so much easier just to decrease the inflammation within the temporomandibular joint. I hope that this all makes sense to you. I don't ask you to believe me. I ask you to look it over. All the information that I just shared with you is there to look at, both information from me and our company, TMJ Services, and it's in the literature. It's in the literature. And so I was just fortunate enough to be able to connect the dots eventually. When I did my first device to unload the temporomandibular joint, I did not know how it worked. I just saw that it worked. And I saw 10 of them work, then I saw 50 of them work. And then I literally had to sit down and figure out why, how does this occur, which I just explained to you. Frequent or recurring headache, earache, jaw pain, neck pain, ringing in the ears, fullness in the ears, vertigo, shoulder and arm pain, arm, hand, finger tingling and numbness and locking. Those symptoms will resolve directly when the inflammation within the temporomandibular joint resolves. So, and I did skip one, the earache itself. And again, inflammation within the temporomandibular joint is right next to the external auditory canal, and the cartilage actually has fenestrations in it. Excuse me for overlooking that one. Inflammation in the joint within the capsule, there are literally fenestrations through the cartilage between the posterior part of the glenoid fossa and the external auditory canal. So that inflammatory fluid, inflammatory, in this case, probably cells, inflammatory exudate, can penetrate the cartilaginous cover on the posterior part between posterior temporomandibular joint and the external auditory canal itself, which will then stimulate the coverings of the cartilage, which will stimulate pain. And the patients will say it feels like an earache, and the ENT doctor or the walk-in clinic physician, nurse practitioner will look at the tympanic membrane and say, I don't see any infection there. The tympanic membrane is in good shape. but oh, it hurts. I mean, literally, when I push on it, it hurts. But it hurts because the inflammation derived from the glenoid fossa from the temporomandibular joint. All right, so we covered all of them. And it follows directly from knowing anatomy, physiology, and a little bit of cell biology. I made my case. I hope that you can pass this information along to other doctors who need it, who need to know it, and can apply it in their practices. Anyone who is following us along who would like to become providers for our company, the Urbanic Device and Protocol, because we have the answer to this, to unload the temporomandibular joint long enough, according to the protocol, to decrease the inflammation. Those of you who are interested can find more information on our website, www.tmjservices.net. You can contact me directly at tony@tmjservices.net, or our Director of Marketing and Education, Naomi at tmjservices.net. We would like to get you involved because we would like to see as many people benefit, as many patients benefit from this who have been underserved one way or another from well-intentioned doctors who do not know this information and who misdiagnose these symptoms, mistreat these symptoms, misdirect these symptoms constantly, when they come in with these disparate kinds of symptoms that to the treating doctor does not make any sense. We see these patients all the time, and we know what to do, and we get the results. So for today, I am Tony Urbanic. This is TMD Mystified. Until next week, I look forward to our next session. I hope you have an extremely productive and successful week.